And welcome back after the two keynote presentations from our Estonian colleagues who share their experience with digitalization and how to make digital mainstream. Now in the Digital Health Society Summit, we would like to move to some practical examples from the countries and from the regions. And the first case study leads us to the Northern Ireland, and I welcome here Eddie O'Neill, who is the Director of COVID Certification Service at Department of Health in Northern Ireland. And Eddie is a medical doctor with extensive and varied experience in performance management, service development. And Eddie is joining us today to tell us what Northern Ireland has learned from the COVID pandemic and to enable digital healthcare services and self-services, and what we all can learn from this example. Hi, Eddie, and great to have you here. I think you joined us back in 2022 to tell us what is the learnings then, and now looking into the future. We are happy to also have you here. So I pass the microphone to you.
Thank you very much. As said, I'm Eddie O'Neill. I'm a clinical doctor and a pretend technologist who's been reasonably successful at delivering technology. Hopefully, I'll give you some insights into that in terms of simple insights. I won't make it overly complicated, although I won't claim to be a genius. In the talk, I'm going to be covering where we're at with healthcare and how digitization can help in healthcare, but also making reference to the retail industry in terms of how we can learn from them, the problems we face, where we are, how digital can help, and what the building blocks are for delivering digital in health. We recently had in the UK the Darzai review, which made it very clear that we've had a decade of austerity, which has affected us with very low capital spending and revenue spending in the health service, leaving us with some of the lowest levels of staffing in terms of developed countries. And more critically, if you look at our bed levels per head of population of extremely low levels, which means we struggle every winter with viral illness. And we took significant economic hits during the pandemic, having to shut down to stop our health service being overwhelmed. So the problems we face are lined up as people are struggling to see their GP. Waiting lists are longer than they should be. A&E's in an awful state. The NHS budget has not been spent where it should be spent, and productivity is falling. These are all quite thorny problems that we have to deal with. The government has talked about responding in three great ways: moving care from hospital to community, shifting from analog to digital, and sickness to prevention. Certainly there's evidence for the second one of those pillars, but the other two, the jury would be out. If you look at Nuffield's publication, this moving care out of hospitals actually increases the cost of delivering that care. So digital shift shift left has not been proven to save money. Our integrated care processes over the last decade in the UK, there's no evidence base to show that it's improving outcomes. And the audit office showed that actually we haven't reduced our overall spend or hospital activity as a result of that. If we look at prevention as a way of solving your budgetary problems, I would ask you to pay attention to what happened in Japan. Certainly, if we invest in prevention, living longer and healthier for longer is great, but eventually you will grow old enough to get ill, and prevention will eventually cost the system more. You'll either get cancer, which costs more to care for and to treat, or you'll get dementia, which increases care costs. And similarly as well, because only about a third of chronic disease is modifiable, 2/3 of it's down to genetics. So eventually everybody will end up with comorbidity and high prescribing costs. Japan had to increase their retirement age, and they also had to increase their revenue take to be able to cope with an aging society. So we come back to digital. Deloitte in 2019 gave us the prognosis we were about 10 years behind other developed sectors. And if we look at Darzai's view on this, we'd really had a decade of missed opportunity. That digital, when it's implemented, quite often makes things worse rather than better in terms of workload for clinicians, and that we're not using data as we should be within the system. There's certainly a huge opportunity in healthcare to use data to drive improvement, but that's simply not being harnessed in the UK, and I would venture in probably many European countries. And it really comes down to, are you connecting dots or collecting dots? And I think really what we need to do here is learn from other areas. If we look at this paper that was published by Oxford University, it was a review of retail. Up to 2009 was about 30 years of growth, but one of the big three supermarkets in the UK stood out, which was Tesco, which had greater profits than its competitors, down to two things. One, that it had UK expansion, but secondly, was a loyalty card scheme. And that loyalty card scheme was key in giving it actionable insights to be able to change how it delivered its services. So if you look at an industry view of this, the greatest value of customer loyalty cards is the data that they generate. It gives you information that you can use personalized marketing. But one of the biggest improvements was they were able to increase their profits at a time of falling margins by using actionable insights to control their supply chain. They were able to model people's behavior based on the weather, time of year, day of the week, and reduce their waste in the supply chain, which produced huge efficiencies. They were able to optimize their store layouts by that individualized data. Healthcare needs to invest in better analytics tools to be able to get those actionable insights to improve what we do, while also, of course, respecting privacy. What you're trying to achieve here is you're trying to improve the degree of intelligence in your information so that there's higher value in the decisions that you make. And that's something we should certainly be looking for in healthcare. So if we look at the problems that Darzai identified in terms of healthcare and how digital can make a difference, if we look at productivity, actionable insights are key to being able to organize your service properly, but digital pathways can also support and enable people to do the right thing first time, whether it's through electronic pathways or through directory of services helping shape people's decision making. Waiting lists, having enterprise scheduling to make sure that things like operation slots or theatre slots aren't wasted because that people haven't scheduled appropriate things like pre-operative checks or investigations, and also simple low-tech solutions like text reminders to stop the DNA rate, patients not attending their appointments. In terms of value for money, you need to link funding to activity and to outcomes. Darzai was quite clear that where that has failed in urgent care, productivity's gone down in the health service. If we look to lessons from Denmark and the Netherlands, emergency department phone first solutions, simple telephone calls to triage patients and a booked service reduced their need for ED usage by 10 to 27% across those two countries, allowing optimization of staffing and better profiling. In terms of lessons from Canada, simple use of video conferencing, where GPs had access to specialists for specialist advice about patients, they were able to reduce elective referrals by 2/3 and also ED attendances by 1/3. We have a choke point in the UK of telephone access to general practice, and certainly digital self-service for appointments, prescriptions, and also for self-help advice can help reduce that pressure, as well as an appropriate urgent care service. If we look at workforce, the paradigm here is that you're trying to end that sort of direct correlation that if you want better services, you need more staff. And certainly with digital, you can break that paradigm through automation. AI, it's on everybody's lips at the moment because of the hype around generative AI. Generative AI, I think, is a bit of a black box with the potential for hallucinations that we shouldn't be too focused on at the moment. I think AI, though, has huge potential for healthcare. If we look at our digital identity solution in Northern Ireland, we were able to automate 85% of our identity checks at 1/5 of the cost of a manual check. If we look at other clinical areas, such as radiology, certainly there's backing from NICE and the evidence base to have a second chair that is AI to help improve the productivity of radiologists because we have a shortage of radiologists. Similarly, if you look at histopathology, there's similar potential there. So you can optimize what happens, but you need that investment. Without that, you're in difficulties. And hopefully the last budget will translate into greater investment in digital. So if you look at the building blocks for delivery, you've got to start off with clear vision. And the clear vision is that your goal is knowledge. And it's about getting up to that top right-hand part of the graph where your business intelligence is improving the value of the decisions that you make. You've also got to understand that if your data quality is poor, you're never going to make good decisions. You can analyze data from now to infinity, but if the primary data is rubbish, your conclusions will be rubbish. So you've got to link funding to health activity for a couple of reasons. One is it improves productivity, and there's clear evidence of that in Darzai's report, but it also creates business rule sets, and your post-payment verification processes drive your data quality, which means then you have better data on which to make decisions. You need to have an integrated data architecture that allows you to move that data around the system to understand the decisions that you're making. And your data strategy has to be supported by your digital strategy so that you're delivering your data as a byproduct of business as usual, rather than something that's a secondary activity. So these things need to be integrated and well thought out. You need to have a clear narrative. If you're going to bring patients and staff with you, you have to be solving problems. So in the UK, we would hope to take the current crisis to promote digital adoption, learn lessons, pivot, and create a new business as usual. That involves meaningful engagement. So during COVID, what did we learn? We learned that there was an appetite for digital adoption. 95% of our certificates for COVID were digitally issued as opposed to paper. So we showed the digital shift was possible through public-private partnership. We could create value for money through agile delivery. We found that delivering complex things quickly was possible by that approach, and that we have products that can now be repurposed, such as our digital identity, which we're using through API linkage to access secondary care records for a patient portal, and also to help with, we're moving towards online GP registration. So I think the current crisis should hopefully drive things in the right way if we can create that narrative for momentum, using digital identity, seeking the problems that people need solving, but engaging meaningfully with the end users and with patients so that they feel part of the process and not just a tokenistic meeting to tick a box. When I talk about an identity solution, what am I talking about? Well, I'm talking about meeting an appropriate standard. So level 2 is the real world existence of a claimed identity, that the applicant is appropriately linked, and through presence you validate that the identity is linked to the individual. So in Northern Ireland, we have delivered that. We start off with a 2-factor authentication. You put in your personal and demographic details. You then upload your photo identity, your passport, your driving license, your election card, and then we auto capture an image of you. So you have to be present, and you activate it with a smile. We then conduct a 24-point authentication of the identity document. We do a biometric check to match your image to the photo identity. And we do a mini credit check to show that there's a history of that person over time. And through that, we achieve 85% automation. Why is this important? Well, for the obvious issue is that obviously with data protection, you only want the right people accessing their own records. And if you're going to build public confidence, you need that security that their information isn't going to be accessible to others who don't have the right to access. But there's also a hidden thing that people don't appreciate. You need line data that you can link to individuals and anonymize, which you can then use to create modeling and actionable insights. What people don't understand is you cannot do appropriate statistical analysis on summary data. So getting identities that you can link data across systems in an anonymous way to individuals helps you to get a better view of the world. And if you have that as one identity for your whole of your public sector, as you start to factor in things like housing, social information, criminal justice information, you get a much more comprehensive view of the world that's less flat earth and more three-dimensional. So how do you deliver it in a cost-effective manner? Well, we've achieved this, so you can judge me by my actions. I invite you to take a look at the NHS Confederation evaluation of what we did during COVID, and was seen to be incredibly effective and value for money. So our symptom checker, we delivered second in the world after 14 days development. Our proximity app, we delivered after 4 weeks development. We were first in the UK and second in the world with that. We delivered those for 2.4 million, that functionality for those 2 apps. That compared to the NHS app, which cost 35 million and was delivered 3 months later than ours. If we look at digital identity, what did we deliver in this space? Well, we delivered a service, fully digital service for COVID certification through digital identity with a fully digital solution in just 4 weeks. We spent 6 million to deliver the digital identity component, which was less than 2.8% of the GovVerify solution. In our solution, we delivered 66% of the population, and they delivered 15%. We delivered 85% automation, they delivered 45%. They abandoned it, and they're spending another 400 million to try and deliver what we've already delivered. So I think that gives clear evidence of value for money and that we did things quickly and efficiently. So how did we do that? Well, it started off that we had design-led engagement with citizens and end users. If you use design process effectively, you reduce the cost of development by having your MVP, or your minimum viable product, closer to an optimal product so that it takes less steps and less development costs. We also as well had non-digital routes for people to maintain a quality of access, but that non-digital route also acts as your feedback so that you can iterate in fewer steps, keeping your development costs down as part of the agile delivery process. Public-private partnership with companies that were prepared to work on a time and materials basis. Decisive leadership. You need people who understand the health environment as product managers to help make sure that digital's embedded in an operationally rational process. You also need agile working. So if you're working to time and materials, having a burn down list that's scoped helps you to set your priorities as you get feedback and learn through development. You also need reduced red tape around your financial approval processes. The longer you take to improve a business case, the more companies will inflate their costs to try and take account of that delay. So rapid decision-making reduces your costs of delivery. And a multi-vendor approach means that you don't have to be an expert. If you have a design company working that's a separate company from your development company, a separate QA testing company, separate pen testing, you can use all of this separation of companies to create a team collegiate approach where everybody marks everybody else's homework. And therefore, you don't have to be an expert. You just have to have enough intelligence to understand what's going on. So if intelligence is the ability to adapt to change, we're hoping across the public sector for an outbreak of intelligence. Unfortunately, those with the best ideas don't necessarily speak up the most. And as we've seen with social media, empty vessels quite often make most noise. I'm hoping that I've kept that fairly simple and kept to time. I'm now open to any questions.
Thank you so much, Eddie. That was very comprehensive. And for all of us who would like to rewatch this again, I repeat that we will have the recordings available on our YouTube channel. We have 1 minute for the questions, so I will actually pick only on one thing. You managed that we should engage meaningfully with our users. Can you give, like, within 1 minute an example or what actually the engage meaningfully means for you?
So, for instance, we were the first to lower our proximity app access to under 16s. We did that through a process of engagement with children and their parents through focus groups where we showed them examples of what we thought were good design. We listened to their concerns about how this might apply to them. And then we designed mock-ups and took a second group of focus groups through in a research process to look at it afresh and to get their view of what we'd done. And in that way, we were able to get the support of the Children's Commissioner because we'd engaged with children and their parents appropriately, and we had the support of the ICO to be able to overcome those concerns about digital access. So I think that saved us a lot of political grief, and it saved us a lot of money in that we were able to develop something that was correct first time.
Thank you so much. Thank you, Eddie, for sharing your experience, your example for all of us. If you want to connect with Eddie for more learnings, please do. And after a short break, we're switching gears and moving to a next case study. Thank you so much.